Hello, everyone, and welcome. Just give it a couple of minutes as people start filing in. In the meantime, I just want to thank everyone for joining us today for this conversation about a new report by the World Bank on fair processes for financing healthcare coverage. So while we still have people joining us, let me just say a very few words to introduce our program today and ask everyone to mute their mics during the talks, of course. So hi, everybody. My name is Monica Magalhães. I'm the Associate Director of the Rutgers Center for Population Level Bioethics, or CPLB. As the name implies, CPLB exists to examine the ethics of macro policy level questions in public health and health policy. And that's why we are so excited to host this conversation about this report that offers guidance on how to institute fair processes for making some of the most fundamental, most macro level resource allocation questions possible that every country has to make in order to move towards universal health coverage. So the report identifies decisions in health financing that are key to achieving equity and really explicitly draws out their ethical stakes. And normally we hear about these kinds of decisions and these processes for revenue sources, resource transfer, cost sharing decisions, service delivery decisions. But we hear them discussed in political and technical terms that don't necessarily make their important implications for fairness and equity explicit. So we're excited to see this report among all of the other things that it does that we'll hear about very shortly. We're excited to see the report argue for the importance of fair processes and also support countries in putting that into practice by offering principles for designing fair processes in health financing that will likely lead to fair outcomes. So to summarize our program today, we'll start with talks by two of the authors of the report, Alex Voorhoeve from the London School of Economics and Elina from the Norwegian Institute of Public Health. Then we'll hear a response by Daniel Hausman, who is on our faculty here at CPLB, and have about 25 minutes for Q&A and discussion. We'll end by noon here in the US East Coast, 5 p.m. in the UK, 6 in Norway. On a quick procedural note, please keep your mics muted unless you have the floor. And in the Q&A, please use the Zoom raise hand function, so I'm sure to see you. So with that, let me hand over to Alex.
Thank you very much for that introduction, also to the Center for hosting us, the discussion of this report, and especially to Dan for commenting. So the report as a whole is called Open and Inclusive Fair Processes for Financing Universal Health Coverage. And I'm going to focus on only one part of the argumentation. The report as a whole tries to introduce a framework for to define what a fair process, a fair decision process is, and then illustrate the framework in a number of countries. It builds on a series of case studies, which I'll be mentioning as well, and then also looks around the world at where countries have been making progress towards implementing aspects of this framework and what the consequences have been of following through on some aspects of the framework. So what I want to do today is I'll introduce you to some key ideas from the report, but my framing will be slightly different from Elina's. Elina will focus more on practice and also taking it forward and work in Ukraine. I'm going to focus on the framework, and let's think also in terms of the values that this framework tries to secure, but also some of the costs involved when you try to secure it in an imperfect world which presents barriers to fully fair processes. And so to help us think a little bit about the trade-offs that countries might face when they're attempting to engage in fairer processes. I have to, of course, emphasize here that this is not a work of philosophy. the report. Of course, it's informed, we hope, very well informed by work by many philosophers, especially in deliberative democratic theory, also on fair priority setting and procedural justice. But it's a work where the primary audience is meant to be policymakers and, say, people in NGOs, think tanks, who directly aim to shape policymakers with their work. And it's the report was a team production. There are 7 lead or core authors, should be said, but Elina and their colleague Unigo Pinetan did really the lion's share of the work, it has to be said. And then others brought in a variety of perspectives. Then there was a very large team of experts who offered repeated consultations. They're all mentioned in the report, would be too many people to mention now. And then a further set of people doing country case studies that we draw on. So what I'm presenting now is my take on the work, but the work is that of many people. So a bit of background. The core question that we were set when we first started working on this in 2019 can be illustrated by this famous WHO cube. So when you're moving towards universal health coverage, the WHO has attempted to visualize this idea by thinking about a cube with 3 sides. On the bottom, we see the question of how many people are covered. And as you extend that to the non-covered, you move towards universal coverage. Then, of course, the question is covered for what? So that's which services are covered. That's the dimension moving towards the back. And you can ask which services are covered now, which services should we add, which services might we need to subtract. And a third dimension then is financial protection. Coverage is usually not 100%, and there may be other costs involved in getting access to medical treatment. So we might ask, what do people have to pay out of pocket in order to access medical services? And that can also be reduced in certain respects. And the idea is that we attempt to move to fill the cube. Now, there are 2 questions that arise, 2 types of questions that arise in moving towards universal health coverage, which is an accepted aim of one of the World Health Organization and one of the Sustainable Development Goals. One of the questions is about substantive fairness, which is how should benefits and burdens be distributed on the path to UHC, and whose needs to meet first when the resources you have available do not suffice to meet everyone's needs. And that was the primary question in an older report on which some people here have contributed, Making Fair Choices on the Path to Universal Health Coverage. But that report mentioned as one of its core principles also an idea of accountability and deliberative inclusion about how to set these priorities, about who contributes to decisions about who gets what, essentially. That was picked up by the World Bank in the 3rd UHC Financing Forum in 2018, and that kicked off the work for this report, which explicitly focuses not on substantive fairness, an issue which it leaves, for example, to that earlier WHO report, but rather responds to a demand for guidance on procedural fairness, how to make financing decisions in an open, inclusive way that's responsive to people's concerns. So if you want it in a simple metaphor, you see that coverage mechanisms, that yellow bit in the slide. If we're going to expand that, we need resources. How are we going to find those resources, and who can contribute to those decision-making processes? Now, what are some of the characteristics of health financing that make this a pressing question? And health financing is here understood in terms of 3 functions. So raising resources, pooling resources, for example, putting everyone in one health insurance pool from which expenditures their health expenditures are paid, and purchasing, what to purchase, which services to purchase. So what are some characteristics? One is their technical decisions. That is, they require, at least in detail, a lot of expertise that is available only to those who have long experience and training in health policymaking. Now, if you look at reports on whether we should have citizen involvement, for example, or extensive stakeholder involvement in decision-making, one of the key things that's often mentioned is technical decisions you should leave to experts. That's, for example, mentioned in a famous OECD report on the involvement of citizens in decision-making. Still, we think that it's important to qualify that in one respect. For the most important health financing decisions, for example, do we have mandatory health insurance and what are the premiums? Do we have a single pool or do we have separate pools for the formal sector and the informal sector and so on? It's very important that the core rationales be widely accepted by citizens. For example, a common theme in unified health systems is that the rich pay more than the poor and the healthy pay more than the sick. Now, that core rationale there is one of risk pooling and of solidarity, and that does need to be understood, even if the technical details do not need citizen involvement. Public money, well, at least when we're engaged in spending public money, which most countries do to a very large extent in the health sector, we need to justify how money is raised and spent, so justification is a core element. Third is that there are difficult trade-offs, and when difficult trade-offs and controversial trade-offs are made, it's very important to ensure that everyone is heard and that no one's interests are misrepresented or neglected, and that those citizens who don't have their needs met, and these are often very pressing needs, or who find their view of justice overridden, not represented in the final decision, at least know that they've received a proper hearing and receive a justification. I already mentioned as part of the trade-offs, it's not merely a trade-off of interest, but also often a conflict of values. And in order to have these institutions function well, and also to meet the demand for public justification, it's important that the stakeholders understand these conflicts and people's differing perspectives on them, and do what they can, when they can, to find common ground when it's available. Another important aspect of these health financing decisions is that power differences among stakeholders are very substantial and they play a significant role. Of course, that's not unique to health, but for example, the medical profession often is extremely powerful. Large drug companies are powerful, and they shape the field of public debate in a way that sometimes means that marginalized, the poor or those with other pressing interests are marginalized. Finally, these decisions are often long-term. Building institutions, for example, that offer coverage for people and reimbursement takes a substantial period of time, and the benefits of these policies and institutions, even when they're executed in the way their planners initially hope, are only felt over an extended period, partly because many of the people who are covered will not feel sick or not need medical care for a substantial period of time. They may pay in for a long period of time before anything is returned to them. And to have the stability that is essential for this to be genuine risk pooling, in which people can feel that their interests will be covered at some point in time if they need it, you need trust and buy-in from different parties. And these really contribute to the sustainability of reforms. Now, what was the approach to the report? So that's the background. Those are the background issues that make fairness in decision-making quite important, and public and stakeholder involvement. There was a core team. There were, over many years, many expert consultations on a series of drafts. And then we also built on a literature review and a series of country case studies in order to extract from the literature, which is not merely in health, but also, for example, in environmental studies and many public budgeting, a series of principles that we think capture the public debate as best we can, so to provide support for the framework that we're about to propose, and the country's case studies to look at what is really going on in a variety of countries and to be informed by that, not merely do a theoretical exercise. And these will be forthcoming this coming month in a special issue in Health Policy and Planning. And these inform the final report. Just to give you a sense of where the case studies are from: Mexico, the Gambia, South Africa, Kerala, Thailand, Ukraine, and Tanzania. In each of these countries, country experts and academics took a look at one recent policy decision through the lens of the framework that I'm about to present to you, and tried to gauge, firstly, how well did the country meet the criteria that we are about to articulate, but also what happened as a consequence of either failing to meet the criteria or as a consequence of meeting them. What were the good and bad outcomes that we can learn from this in these given countries? So how do we end up defining open and inclusive decision making? Well, partly it may help. This audience hardly needs reminding, but I'll go very quickly here to contrast it somewhat. So we do significantly build on their work with a prominent answer in the field, namely Norman Daniels and James Sabin's accountability for reasonableness. Their proposal, which has primarily been applied to what we call the purchasing element of health financing, or what to provide to people in return for their insurance premiums or their contributions to the state budget. 4 principles: publicity, decisions and their rationale should be publicly accessible; relevance, which I take it to mean that rationale should be reasonable, that is based on reasons, evidence, reasons and principles that will appeal to fair-minded people who are disposed to find mutually justifiable terms of cooperation. So this is a Rawlsian idea. Then there must be revision and appeal. There must be mechanisms for challenging decisions and for dispute resolution. And finally, regulation. So these 3 principles must be institutionalized, and there must be regulation establishing them so that they properly work. In a nutshell, the view we came to in the overview paper, which is about to be published in Health Policy and Planning, and which provides background for the report, is that this framework is important but limited. It's too limited. And the most important ways in which it's limited is that it leaves out aspects of voice, especially inclusion and participation, and it leaves out an important aspect of equality of access to information and equality of influence. So you may think of the report as proposing to move beyond the framework in these respects, and in addition to apply open and inclusive decision-making, not merely to the purchasing or who gets what with the resources we have function of health financing, but also to the revenue raising and pooling decisions. So here then is the proposal. We started by boiling down the vast literature in a number of areas into 3 core principles, is our proposal: equality, impartiality, and consistency over time. And then we said that there are 7 further principles that, or criteria we call them, that derive from these core principles. I'll just briefly comment on these 3 core principles. Equality here is understood not in the sense of substantively equal outcomes. That's about substantive justice. This is about procedural justice. It's about equal representation and consideration, especially regardless of social status, gender, ethnicity, religion, income, or power. It's about equal access to information and an equal opportunity to articulate views and contribute to the debate on the issue. and that such views are considered with equal respect. Now, equal respect here does not mean that everyone gets believed. Now, Elina says something I disagree with, and then out of respect, I have to put up with it. Respectful engagement means we debate, but I don't dismiss it merely because she's a woman, for example, or from Kyrgyzstan, but instead we discuss it with each other on the merits. That's what equal respect means. And given the skewed power balance that's normally the case in public decisions on health financing, it therefore has a strong pro-poor and pro-marginalized impact. But in its essence, it's not about substantive, but more about procedural equality. Impartiality here means that deliberations and decisions are not biased or driven by agents' narrow self-interest, but rather by equal consideration. So, of course, it connects very strongly with the notion of equality I've just articulated. And to just illustrate it from one of the many papers that informed our conception of this criterion, in Malawi, a fascinating paper by Tweya discusses how a new funding formula was going to be developed for health centers in the regions, for allocating money from central to regional health facilities. And in discussing this formula, all the regional heads were invited, but the regions were anonymized. They were merely given generic descriptions, and just a few core elements of their characteristics were mentioned in order to illustrate what the funding formula would mean for districts with this type of, say, health need, population, etc. The idea there was, of course, to get people around the table out of thinking what's right for my district, and instead to start thinking and offering reasons in terms of general or impartial considerations. Good. So consistency over time is really just about there's several elements of it. One is that, of course, people have to be able to count on the idea that once a decision is made, that it will remain for a period, at least until properly challenged through pre-existing channels, that it's not a mere decision made at whim and that can be changed at whim, but rather one that's based on deliberation and reasoning. So that's the notion of consistency over time, not that you stick with something forever, but rather that any changes come about as a consequence of proper deliberation themselves, and that parties to a deliberation accept, once a decision has been made, they accept that as final, pending the standard forms of revision. Because it's important that people are able to count on these, on the decisions that have been made, especially in health financing, where the benefits, if they're to be secured, are such long-term issues. So building on these core principles, what are some criteria? One is in the information domain. The reason-giving element is reminiscent, of course, of Daniels and Sabin's view, but it's more dialogical, the way we put it. So Daniels and Sabin's view seems at least to be consistent with, we simply provide public justification for whatever decisions are made, if we are the decision makers. But the way we understand reason giving is, it is more demanding of a kind of dialogical engagement with relevant stakeholders. So that's building on their work, but extending it. Transparency simply means, decisions, the content of decisions and the reasons for decisions are made public, publicly accessible, checkable. Also, the aims, what we aim to achieve, is public, so that people can hold decision makers to account and those who are meant to carry out the decisions. And finally, a criterion of accuracy of information, that's to say, decisions should be made on the best available information. To anticipate something Dan might say, because he helpfully put it in an email to me beforehand, you properly speaking, perhaps this criterion should be called accuracy and comprehensiveness of information, not merely that you should use it whatever you use is accurate, but also should be as comprehensive as possible or as reasonable. Another dimension is voice. You'll recall that this is what we claimed was substantially lacking in the famous Daniels and Sabin's view. So inclusiveness, of course, follows on from our notion of equality. That means that no one should be left out, no important stakeholders should be left out, and lots of different views should be considered, as well as, so to speak, more people. Different views should be considered, heard, and weighed with respect. And participation means people have to have really a substantive opportunity to participate in core elements of decision making, which is then means not merely, you're invited to join in, but we make a substantial effort to break down the barriers that hold people back from participating, especially from marginalized groups. Finally, this is reminiscent of Sabin and Daniels' enforcement condition. We have oversight. So there's revisability of any decisions that's made, but through proper channels. And then there's enforcement of all these other criteria and the process that they require. Now, this may seem extremely idealistic, especially given that this is a World Bank report for a world which is very far from democracy, even in some of the oldest democracies. And deliberation, even in democratic contexts, often falls very far short of the ideal if all criteria here were perfectly met. Now, the report has some interesting things to say on this. That here's a take-home message. Firstly, it's not all or nothing. It's a matter of degree. And sometimes there are cases in which, for example, one of the criteria can be sacrificed. For example, really engaging in an inclusive dialogue with lots of participation because it's simply too technical a decision. But we can then still compensate for, in part, or make some progress by ensuring transparency of decision making and the public making public the reasons and having ability for people to challenge it. So satisfying these criteria is a matter of degree. And another important lesson is that in certain contexts, non-democratic contexts, I'll mention Thailand as one of our case studies, great progress is possible. For example, Thailand has made very substantial progress on inclusiveness and participation along, for example, in its deliberation about what to cover in its universal health coverage system by paying the poor or contributing to public deliberation by inviting, say, marginalized groups to make representations to the panel that makes these decisions. So that's a country, of course, under military dictatorship. So what are some of the pros? Why should we say to policymakers and to each other that it's good to have open and inclusive decision-making as we define it? There was lots of debate, of course, about this in the group, and I'll explain the 4 criteria that emerged as a consensus. First is that it can contribute to fairer and more effective policy. In a way, it's perfectly straightforward that if you try to make your deliberation more inclusive and seriously consider the interests of all, including those which are normally the poor and marginalized who are excluded, it's more likely when their voices are heard and when their interests are seriously considered that we will avoid merely doing whatever serves the interests of the powerful, if you really manage to counteract the power imbalance there. So that is the core idea. But there are other connected ideas. Transparency, accuracy of information, and revisability are simply very important to making sure you're making decisions based on the right evidence. And they're available, they help you correct mistakes. As I mentioned, voice ensures that marginalized groups are heard, which helps make for policy that serves them. And here is an example from one of our case studies. There's extensive, of course, history of public participation in decision-making in the Indian state of Kerala. One of our case studies studies the 2016 plan to make primary care more accessible, better funded, and the first point of health system contact, which was preceded by extensive public participation, which built on the pre-existing institutional system there. Another one is Thailand's process of deciding on whether to include pre-exposure prophylaxis for HIV, known as PrEP, in the publicly funded benefit package. And this involved lots of deliberation with especially the groups, for example, sex workers, gay men with multiple partners in short periods of time, who you might normally not hear of in public deliberation, but those were the populations who would most benefit from the availability of PrEP. And their inclusion, like in Kerala, was part, like in Kerala, the inclusion of the poor, was part of an institutionalized approach to evaluating new health interventions. Now, one lesson here is that countries that managed to do this, or regions, Kerala and Thailand, did so successfully only after substantial investment in the institutions that enable this form of inclusive deliberation. So the second benefit is that it can strengthen legitimacy. And we should here distinguish between two forms of legitimacy. And a simple way of distinguishing it is saying normative legitimacy is that the state or the public agent, because we're often dealing with parts of the state or a public agent, is morally justified in its assertion of its authority and can create moral obligations to obey its commands in its area of operation. And descriptive legitimacy is the de facto acceptance of such demands by the stakeholders or citizens and the need to obey it. What's the connection between these two forms of legitimacy and a fair process? We propose that, in fact, a fair process advances both normative and descriptive legitimacy. Because the process itself treats people with equal concern and respect, and is concerned with giving them justifications for the decisions that it enacts, this contributes to normative legitimacy. It gives people better reason than in the absence of a fair process to recognize its authority. And de facto, it also does, in fact, make people more willing to accept and abide by these decisions, even when they go against their interests. And the interesting thing is that, of course, the second part is an empirical claim. The first is a normative claim. But this empirical claim seems to be quite strongly supported by the social psychological literature that we surveyed. So here's a quote from a famous article by John Tyler, a social psychologist. He says, when third-party decisions are fairly made, this is summarizing the evidence at the time, people are more willing to accept them voluntarily. The procedural justice effects are found in studies of real disputes in real settings involving actual disputants, and research suggests that people voluntarily cooperate with groups when they judge that group decisions are made fairly. We may ask ourselves, why does this link exist? So I think there's a good Rawlsian explanation, which I will skip in the interest of time, but the basic idea is that it resonated with me that Rawls says one of our key motives is a sense of justice, where we desire to contribute to public decision making and abide by fair rules when we feel that others are doing so too. So the idea is essentially, I think, a kind of Rawlsian motivation may explain this link between a fair process as we define it being followed and people being willing to submit to decisions. So the third and related benefit is that it's meant to build trust. Transparency accuracy of the information on the basis of which make decisions, and the provision of public reasons in a kind of dialogic manner. Right? So we debate these reasons and then offer final reasons for the decision, provide people grounds for increased trust in the authority because they make the decisions more reliable, and because there's this check on decisions, and the ability to expose corruption. So transparency, for example, to look at another one of the countries that we focused on in the report, has shown there's a clear link between making the procurement decisions more transparent and a reduction in corruption. In one study we cite in Ukraine, moving to a more open platform for medical procurement rather than just following old boys network back channels led to 20% lower prices. Inclusiveness and impartiality also supports trust in the sense that I trust that my interests have been properly considered, and especially those who have reason to mistrust authorities because they feel their voices are not heard will have more reason to do so when the decision process was genuinely inclusive and impartial. And this was also found to be the case in Thailand. Interviewees, so it was a qualitative study that we drew on, often cited the fact that the inclusivity of the Thai priority setting process fostered public trust. The fourth and final value here is that it's meant to improve sustainability of reforms in the sense of durability. You'll recall that I mentioned at the start that for reforms in the health sector to work at all, they need to be sustained. They work over time. And we think that there's reasonable evidence, though of course in social science everything is up for debate, that inclusive and participatory decision-making can improve sustainability. Think again about what I said close to the beginning, that we need, even though decisions are technical, we need to offer the public a rationale for, say, a reform that mandates health insurance contributions, or that generates a single pool where previously there were fragmented pools, one for rich and one for poor. To get support, enduring support, people need to be convinced of its core rationale. Another element of fair processes is that they aim to achieve common ground where it's possible. It's not always possible, but when it is possible to do so, then when you build on common ground, naturally, when power shifts between different parties, you can still retain the existing institutions. So here's an example from a country that I know better in its reform process, which we did not cover in the report. The Netherlands health financing reform, which brought us in the Netherlands universal health coverage, was passed in a coalition government between Liberal and Christian Democrats, so center-right, but it was prepared for many years, by some counts for more than a decade, in extensive deliberations led by Social Democrats, Christian Democrats, and many others, and many stakeholders, so that by the time it was voted on in Parliament, it was ready to survive any changes in coalition, which are very frequent in the Netherlands. Now, let me talk about some costs, and then I will conclude. I'm sorry, I'm conscious that I'm over time, so no more than 4 more minutes, apologies. One cost of following this is that deliberation can take a lot of time. I just mentioned 10 years in the Netherlands to prepare the ground for a new health financing system, but the window for change may be short. Here in Ukraine again, Elina will comment on this in a moment. In the 2016-17 health financing reformers perceived a very short time frame to pass key legislation to improve a gravely dysfunctional health system. They did not have 10 years to, in the Dutch style, deliberate with each other. Now, they pushed it through quickly, and this is one thing that we, in a forthcoming article, we discuss, also based on a qualitative study with people involved in it. He's one of the co-authors who was also Deputy Minister of Finance at the time and lead advisor to the Minister of Health. So they pushed it through, but it had its costs. in turn. He says, I was on the side of the proponents to deliver as soon as possible. We were struggling to involve people in a meaningful conversation over whether to have a predominantly payroll-based system or a system based on general taxation. I now see that the dilemma was not a technical one, but about whether to have a system based on a personal link to entitlements or on solidarity. And that is what we should have communicated. And he feels that the lack of the ability to communicate that core values-based choice led to a lot of subsequent pushback. Now, another problem is, of course, that powerful interests may hijack deliberation. And there's justified fear also seems justified when one reads the literature on public deliberation, that if you open up deliberation without fully leveling the playing field, what you get is even more pathways to influence for the powerful. So in the sugar tax in Mexico, which is another one of our case studies, here's what the authors say. For some stakeholders, there was no consultation, dialogue, or justification of the proposed tax prior to its presentation in Congress. It was intended this way because they felt the stakes were too high to open up to discussions beforehand where these players, industry, would have had a disproportionate influence, so they feared. So there may be tension between openness, inclusivity of key stakeholders, and the kind of equal consideration dimension. The third is that without well-developed institutions, implementation is going to fall short. So you may aim for more open and inclusive decision-making, but we saw that successes involved, say, Thailand, where you had, and Kerala, where you had very well-established, inclusive, deliberative institutions. The case study about the Gambia involves its passage of the National Health Insurance Act, and there was an intention for open and inclusive decision-making, but really those around the table were technocrats and health insurance companies, and there were no consultations with citizens or health workers, in part because there was simply not the proper experience and network in order to allow this form of deliberation. The National Assembly schedule was also too full to allow, proper consultation. So lots of normally marginalized groups were indeed excluded. And this is another case study that's forthcoming. So what then is the key recommendation? If you want the benefits of open and inclusive decision-making in the sense that we've defined it, so increased trust and legitimacy, better and hopefully more substantively fair decision-making, and more durability of reforms, and you want to try to avoid some of these costs, the key recommendation is invest in what's called deliberative capital and in institutions. So the case studies that seem to be indicate more success are countries that have cultivated knowledge-generating and participatory institutions and strong civil society organizations that represent the interests of the less powerful. And here, I'm drawing on the work of Sahi, who discusses the need to stimulate investments also, not merely institutions, but attitudes, which he calls deliberative capital, which is mutual understanding, a willingness to listen, and a willingness to move beyond narrow self-interest, and social norms that codify these attitudes. Because in the absence of this, there's trouble brewing when you attempt an open and inclusive conversation. Okay, thank you very much.
Thank you, Alex. We could move directly to Elina's presentation. You ready to go?
And then slideshow, sorry. Can everybody see? Yeah, okay, good. Perfect. So thank you, Alex. I think Alex kind of laid out the field quite well now for me to pick up. And just to say that now I will present you a case study from Ukraine, which and my talk will build on the case study that will be coming in the health policy and planning, but it's kind of looking a little bit beyond it and looking at kind of where we left off with our case study that will be published, which was before the full-scale invasion of Ukraine in 2022. And this talk I prepared together with Katya and Yuri, who have been actively involved in health financing reforms in Ukraine. And Yuri has been kind of a lead policy maker in the serving in the Ministry of Finance. And just to say that now he has joined as a Deputy Minister of Defense. So he will have lots of work to do. and let's see how the process goes there. But and this also comes a little bit prepared with my personal kind of experience of having worked in Ukraine before the full-scale invasion and also being involved in the work now. So this is just a timeline kind of all key milestones that I think important to consider when we talk about the health reform in Ukraine. And we need to go all the way back to understand some of the things that Alex hinted on the window of opportunity. We need to kind of go back to the 2014, to the so-called Revolution of Dignity, or the Maidan Revolution. And because once this revolution happened in February 2014, after many months of protests, this kind of ushered a new era of reforms. Decentralization and health reforms were very high on the agenda because they had to respond to social demand to strengthen civil rights and tackle years of corruption and mismanagement, particularly in the health system. So already in 2014, a new system of procurement of medicines and medical supplies was piloted to improve the existing system. And Alex already gave you some kind of incredible results on what it brought once they instituted a much more transparent system for procuring medicine. Then in 2016, an outsider, Elina, a Ukrainian-American physician and philanthropist, was brought as the Minister of Health, as an acting Minister of Health. She brought in a young, quite idealistic team with the task to overhaul the health system, which was considered inefficient and outdated, with large hospital network and very weak primary care, which was basically not reformed since the Soviet times, and was very high, one of the highest out-of-pocket payments in Europe. So then in 2017, late in 2017, a landmark law on government financial guarantees of healthcare services, or called Program of Medical Guarantees, or PMG for short, was adopted, which really provides the framework for all the following regulations and for the current health financing system in Ukraine. And then in 2018 and 19, there was already a series of things happened. Everything was moving very fast. National Health Service of Ukraine, which is kind of a purchaser of health services, opened its doors. Primary care was completely overhauled. They introduced the affordable medicines program, which covers outpatient medicines for several priority conditions. And also the out-of-pocket for medicines was one of the key drivers of, was one of the key drivers in kind of financial risk. And so then in 2019, there were elections resulting in changes in the government, with a new party coming into power, the current party of President Zelensky. So the time between 2016 and 2019 can be characterized really by this feeling of urgency in health reform, where it was felt that reforms needed to move fast to ensure that people were not disappointed after the revolution of dignity. And because it was kind of for the team of Elina, it was increasingly clear that a new party would come to power. So this was really pushed reformers to move faster and faster. I remember when I came to Ukraine, I learned this new expression called turbo regime, which meant that some reforms which took, in my experience of working in other countries, years, they had to be done in months or weeks, sometimes in Ukraine. So in 2020, even under the COVID-19 pandemic, the reforms continued, although increasingly there were questions raised in media and in the parliament on whether the reform was going in the right direction, whether it delivered what it promised, whether health workers were listened to. And then, of course, you see in February 2022, there was a full-scale invasion of the country. And whilst the first few months, of course, all the focus was on the emergency, the country adapted, and the health system continued to also adapt and look for new solutions. And the amazing thing is that they never abandoned kind of the vision of the big reform agenda and moving away from the old system. And so the reform kind of continued. So the key features of the health financing system, kind of before the reform, there was a vague constitutional right to medical care guaranteed by the state. And you can look at the other ones here. And then there was important kind of characteristic of this old system that, there was this type of payment system that incentivized bigger hospitals. Doesn't matter if there are patients or no patients, but more doctors and things like that. And after I call it the first phase of reform, kind of with the PMG law, there was a more defined set of the entitlements, which was covered by the state, and it was called Program of Medical Guarantees. Then, importantly, there was a real shift in how providers were paid. So it was no longer that, the bigger the hospital, the more beds it has, it gets more funding, but it was more how many patients get treated there, what types of services they provide. And so, of course, this had to generate, some, let's say, disagreements and some discontent, which I'll highlight more in the next slide. So some of the areas of kind of disagreement relate to revenue mobilization, so sources of financing, and for example, the extent to which this new health system should be financed from the general taxes, or should it have health-specific contributions, for example, payroll tax. There was also discussions about the out-of-pocket payments or user fees and the role of this kind of out-of-pocket payments. Should there be any, should there be none, or should they be for certain services? And then purchasing, both the kind of the scope, if you remember the cube that Alex was referring to, so the scope of services, what's included in this package, and how they're defined, and then also payment methods for special services. As I said, that this kind of shift to output-based financing really, you can say, that hurt some very big hospitals a lot. So then this is just you don't have to really understand this whole slide, but it's just to give you a sense, because I keep talking about this program of medical guarantees and the service packages. So this is just kind of visual representation of this benefit package, you can say, in Ukraine. And as you can see, it is quite broad, ranging from basic primary health services to services such as hemodialysis or chemotherapy. Some packages, however, are very broadly defined, and others are very specific, for example, TB. And yet others are more around inputs, not services like to patients, right? But for example, special salary payments for those working in the active combat zones. Also, service packages under the program of medical guarantees keep being added, but there is no real process around how they are added. They appear to be done sometimes on an ad hoc basis, sometimes politically driven. For example, when I was still working in Ukraine, there was a service package in 2020, added to placate largely health workers from the hospitals, which were losing money as a result of the new reforms. Also, the question is whether new packages that are added, even if they make sense from a clinical effectiveness or cost effectiveness perspective or patient preferences, if they're affordable. So in this context, despite the war, the Ministry of Health of Ukraine set up a working group, which is mandated to look at least at some of the most urgent issues related to PMG. And the question is then, what lessons can be learned from previous reform process and how this can be done to ensure that citizens feel that their voices are heard, that the government in the country which they defended with their lives listens to them, respects them, and engages with them, and that decisions are done transparently, and that they explain to the public and are based on evidence and not unconstrained self-interest of those in power. So with this in mind, as I said, the work kind of has started on setting up the working group and looking at this program of medical guarantees. And so we are trying to look at some of the lessons that we can draw from the previous kind of reform phase and see, so what is it that we can do better this time? So in the previous, as you can see, this is kind of a recent poll. And as you can see, there is a anti-corruption healthcare, a very high on the agenda, on the reform agenda, according to this poll in the current situation in Ukraine. And it's very important then in this kind of situation that the new reform process of this PMG, that it is kind of characterized by transparency, reason-giving, accuracy of information, participation, inclusiveness, and enforcement of those decisions in order to ensure that there is kind of public trust. And this understanding that this has to be done a little bit differently this time is, at least among some of the architects of the previous reform, it's there. As Alex showed with the one of the last slides in the quote, I think there is a realization that maybe sometimes the speed of the reform, of course, it's a dilemma, but still there is a realization that you have to kind of think through whether it's worth giving up some of these things in order to have the speedy reform process, and that the value of the process is just as important as the kind of technical content or substance of the reform. So then one of the key lessons I think that we learned from this previous reform phase is that you need to invest time and resources to actively engage with citizens. So as I mentioned that there is a growing sense in the country, and there are different polls that show that there is this kind of sense among the population that they have to be part of whatever decisions are being made. And so there is a high kind of demand for democratic rule. And the lessons from the previous reform showed that when citizens are not viewed as active kind of participants in the reform, as active participants in the dialogue, but are more viewed as listeners, as people to whom you market the reforms, then they might not understand the reforms, and you might not understand what people actually want in these reforms. And then as a result, you don't have support from these people, from the population. Of course, this requires time and funding, and also there's like certain tools that you need to engage citizens. And some of the reformers, they reflected on this and said, yes, of course, it would be nice to engage citizens, but how do you do it effectively, feasibly, right? And that, of course, becomes even more difficult in a wartime, in war times. So there is thinking and discussion about how to develop mechanisms for effective civil society engagement and for effective citizen engagement as part of the overall restructuring or overall review of this PMG. Maybe there's one can use the population surveys, which are still being conducted more consistently, more effectively, and kind of at least try to see what people think and try to make sure that they're not seen as passive recipients of this reform, but seen as kind of shapers of this reform. Then the other lesson that was learned from this kind of previous reform that I was discussing, the turbo regime reform, is that there is a need to use diverse set of evidence or diverse sources of evidence. And I think Alex referred to it as like comprehensiveness of evidence, not just accuracy, or comprehensiveness of information, not just accuracy. Because there are certain types of policy questions in health financing that do not have like right or wrong answers. And you can, I mean, evidence is ambiguous, and you can find, of course, documentation for different things, right? And especially in places like Ukraine, even before the full-scale war, there was some data was really, questionable, or it was outdated, considered unreliable. And so, especially in that kind of environment, it makes even more sense to say, okay, this is what this source of data says, and this is what other source of data says, and let's consider it together and not dismiss from the start by saying, okay, this is really, I don't believe this academics, or I don't believe this university, they're not good enough university, so I shall not consider the evidence. So, and what we found that there is a really need to not only look at global evidence or other European evidence, let's say, or but also look at the local work and look at the local research groups and universities and work with them and maybe build their capacity also instead of dismissing them. Then the other lesson is that one has to be open about trade-offs and dilemmas. Now, it's not so easy, I think, in all circumstances. I know, for example, in Norway, during COVID times, there was a real effort to be always open about the trade-offs and dilemmas, and making sure that, people understand that, for example, we don't know everything, or if this measure is taken, it will have the following consequences. It's not always easy in some of the countries that I have worked with, including Ukraine, but it still seems to be worth at least trying, because, for example, in the previous reform process, it might be that people expected that out-of-pocket payments may decline faster than the reality could afford it. And I think they not being explicit about it and led to disappointments and kind of lack of trust. I'm not sure what happened. Okay. Now, then the other point is that there has to be a process for regular revisions. So the stakeholders must know that this is not like the only chance to change things, that there will be, if new evidence comes, there will be a chance to change or to reconsider things. And the recent review of the benefit package design in low and middle income countries found that there is actually revisions of benefit packages that happens very rarely, it seems, even when it's mandated by law. And so it's important that this is actually taken seriously, and there is a regular process for revising that is structured and systematic and not ad hoc. And this is important, even more important for young systems such as Ukraine, where there was like not a lot of country data when the first wave of reforms happened, right? And so now the data accumulates, the capacity grows, and so it's important to have this process for regular revisions using new data that is accumulated. But as Alex said, all this requires time, but the opportunities can be fleeting. Resources, capacity, both on the government part, because they need to understand the value of process and also have tools, because even you can understand the value of process and say, okay, it would be great to engage citizens, but how do you do that? It's not always very clear, or the government might not always have that knowledge. Then the local researchers and civil society need to have, we need to grow their capacity. And then what do you do in a society which historically had a lot of distrust in public institutions, large differences across income groups, high levels of corruption, and now has been ravaged by war? And with that, I stop sharing and over to you guys.
Thank you so much. Let me just say, since we are a little bit behind schedule, I'm checking on whether our speakers could stay a little bit after time so we can extend the Q&A a little bit. In the meantime, let me hand over to Dan Hausman for his comment. Dan, please go ahead.
Thanks. Given the time, I'm going to be very brief. Instead of giving a whole spiel, I'm just going to list a number of qualms that I have. The first qualm is, it seems to me very odd to have this almost, really exclusive concern with processes for deciding on how to finance health, without any discussion of substantive principles that we might want to embed in our healthcare financing. I realize that some of this has been addressed elsewhere, but nevertheless, it seems to me that the procedural concerns really should be linked with the substantive concerns. To put it in a simple way, if we actually have a good set of principles governing the actual financing of healthcare, why should we care about our procedures? So that's the first qualm. The second qualm is, and this, it's possible I may just be misled by some of the terminology and the title itself, is it seems to me that a lot of this has nothing to do with fairness at all. The principles that are listed in terms of governing open deliberation, impartiality, one can see very clearly is linked to fairness, but I'm not sure that consistency, accuracy of information, equality itself, the way it's used here, I'm not sure that these really have much to do with fairness. And that at least is a confusing feature for me. It may just be a terminological matter. It also seems to me that there's a variety of different interests and concerns that these procedures are designed to satisfy. So one theme in this is how do we get the population to feel that what's going on with the funding of healthcare is legitimate? And for that purpose, basically one is using the procedures as a way of reassuring the population, of bringing the population on board. Whether the procedures are getting us good answers or bad answers really doesn't have much to do with it. It's rather to what extent are they helping to pacify, as it were, the population. Now, there's another regard whereby one can think, well, we really need these procedures in order to be making better decisions. But if you think of the procedures that are likely to make better decisions, and the procedures that are likely to make the population feel that what's going on is legitimate, it's by no means to me obvious that the same set of procedures are going to be satisfying these very different roles that one envisions these processes operating in. So I think with just those three qualms, I think that's enough for me to be talking at this point, because it really would be a good idea if there were discussion from the audience as a whole.
Thank you very much, Dan. So I will waste no time and open the floor for comments and questions. Please raise your Zoom hand, and let's go to Leah.
Hi, yeah, thanks for the really interesting talk. I think I'm really going to actually pick up on Dan's points here. So, yeah, I take it that one of the primary justifications for relying on fair processes is that doing so was likely to produce more fair decisions. But then we were given lots of reasons to worry about whether actually making processes more inclusive and deliberative was going to have this effect. You know, Alex, you mentioned this issue around this like lack of established sort of institutions for making processes like actually deliberative and participatory. And this seems like sort of in part practical problem. Like we just don't have the infrastructure to do this. In lots of countries, they're spending less than $40 a year per capita on healthcare. Like this is expensive. This like in the status quo seems hard to actually do. But then it also seems like there's sort of this more theoretical worry, which is that a lot of the kinds of care that we might think have natural advocates are not the same kinds of care that we might think are the most cost effective, right? Like there's no pap smear lobby or depression screening lobby. There are, however, lots of people who want access to expensive drugs that will provide them really significant benefits. And so I guess my worry is like, it's not obvious to me that the sort of more deliberative, inclusive process that you propose is actually going to lead to these more substantively just decisions. And in fact, it seems like we have good reason to think that it won't. And so I guess it's like there's some argument for not at least collecting some empirical evidence on what the effects of making these policies more deliberative and participatory is, and then assessing on that basis whether we should actually implement them.
Thank you. Monica, what do you propose? Shall I respond, say, to two at a time, and me and Elina? So can I take Daniel's and Leah's points and offer a brief response, or would you like to take more questions?
I suppose I could respond.
Okay, good. So thank you both for your challenges. Why should we care about procedures? But there's two approaches that we take in the report. The first is that we think, at least under some circumstances, there is good reason to believe that these procedures are instrumentally good towards achieving forms of substantively better policymaking. And at least for elements of those procedures, we do provide evidence in the form of case studies. Now, of course, that's only one form of evidence in this area. You could have other forms of, I'll take all countries who've done a particular measure, did it work or not, and so on. But given the complexity and context dependence of whether things work in one place or another, that's a challenging thing to do. So we chose the case study method here. And the case studies mix quantitative and research, but they're primarily focused on qualitative research. So interviews with people involved in the decision-making process and assessment of the outcomes. So this instrumental link has a very basic, plausible idea, which is if you attempt to bring in not the voices of people who are usually marginalized and whose interests are underserved into a process so that they're properly considered, for example, those people who most benefit from pre-exposure prophylaxis in Thailand, it's key to overcoming, say, barriers, stigmatization, discrimination, and so on, that they are heard. And moreover, you get better policy because they know things about their own lives and about the way proposed intervention will or won't work for them, because they lead non-standard lives, right? That people around the table making the decisions might not think about, that can really substantively improve the policy, both in terms of substantial equity and in terms of just, intelligent policy design and effectiveness. Now, showing it in one case, you're right, Leah, doesn't show that it's the case everywhere. And so I think it's simply the report calls for, careful judgment and gives a series of examples of cases where things have worked and things have not worked. That's about the instrumental link. I do think, however, that there's also intrinsic value to a fair process. It's not just, Dan, you put it provocatively, I know, that it's not just about placating the populace. It's about ensuring that in the face of these difficult trade-offs and disagreement about what is just, about what is substantively just, people are heard. And I think it's very important, both for trust in the process and simply because we owe it to individuals to listen to them and their concerns and take their views seriously and respond in a dialogical manner, not merely say, I've thought about what you said, Dan, here we go, but rather attempting to respond and learn in an open-minded way from what other parties say. I think that's simply what we owe to part of what we owe to each other. We don't owe each other merely, say, medical treatment or a certain amount of financial payment. We owe each other this type of attempt at dialogue, at least when these core issues are at stake. So that's part of the reason why there's both, in some circumstances at least, this instrumental link, and more generally, you might call it the intrinsic value of this process. And of course, legitimacy that is not merely about pacification of the populace. It was very interesting to me. I'd never read this literature before engaging in the report and research for the report, that the social psychology seems to bear out what is also, in a sense, plausible, that having a decision imposed on you, even if it is substantively just, feels very different and occasions also a very different response than a decision in which you feel, even if you disagree with the final view or it goes contrary to your interest, a decision in which you feel your interests and those of others were considered in a fair manner. So I hope that answers some of Leah's and Dan's concerns. Elina, did you want to add something?
I think just to say that quickly, I think, Leah, you mentioned about the strong interest in the patient groups, right? Yeah, for example, primary healthcare, or I know in health, right? It doesn't have like a single patient issue group that is very loud, and that. But I think that is the point, right? If you don't have this kind of deliberate fair process, then those the loudest or the most resourceful will find a way to influence the process, right? The case in point being, for example, when you procure drugs, I know in Ukraine through a very opaque process, right? But then if you open it up, if you're transparent throughout the process, you publish every time you make the first announcement and who is and you document throughout, and you maybe include citizens from a broader public, not just the organized patient groups that are typically very vertical, narrow issue patient groups, then it is plausible that it actually will lead to let's say, to ensuring that those people who are not organized and maybe less powerful or less have less voice actually get heard, and there will be the final decision will be more in their favor also, not just the people who are behind this opaque process or the narrow patient groups that manage to get into that kind of circle.
Thank you. Given that the time is shorter and the queue is longer, shall we do the next round 3 by 3 people and then 3 people? That might be a bit demanding, but that would give us the time. So let's do Francis, then Mike, then Nir, and then responses. Francis?
Yes. So what I just wanted to get clear about this idea of solidarity. I think Alex began by saying that people involved in this discussion have to realize that it's not about self-interest, looking at things from a impartial point of view, and solidarity was mentioned. But I wanted to get clear on whether to have a system, a universal health system that provides everyone with the same plan is what's meant by solidarity, or whether discussion can be impartially engaged in about whether to have solidarity in that sense, namely a plan, the same plan for everybody. I noticed that in the Ukraine system, there were different packages, perhaps depending on what people, how much people cared about, you know, avoiding risk of not being without care in certain unlikely circumstances, how much they were willing to pay. And I didn't know whether the degree to which one was going to think of oneself as in solidarity with others was also something about which one's voice could be heard from an impartial point of view, allowing for different packages. Thank you.
Shall I jump in now? So the considerations that you offer in favor of more sort of user or citizen participation in the case of health policy clearly generalizes to a whole range of other policies, like pensions, schooling, tax policy, spending on infrastructure, as opposed to other things. It can't just be focused on the one policy. But of course, we couldn't have, I mean, in a relatively large society, we couldn't have people actually in this participatory fashion doing the legislating and the issuing of regulations and policies. It's ultimately going to have to be through representative institutions. And so does this then ultimately come down to the proposal that, well, representative institutions should be, you know, sensitive to and try to get input from the users through hearings, you know, open hearings and the like, and lots of information gathering policies, as opposed to something more radical, basically the overthrowing of representative democracy with something which is much more directly participatory.
Here, you're muted. Here, you're muted.
So I'm saying I could. I'm gonna probably MC the Q&A in a few minutes once Monica needs to go. If people are willing to stay, and then I'll have the power to take the moderator's prerogative. I'll take the prerogative of the moderator to ask my question. So maybe I'll let Alex and Elina address the question so far.
Okay, thank you.
Sorry, go.
May I? Yeah. So thanks, Francis, and lovely to see you, even at such a distance and small on the screen. On solidarity, yes, I did not mean to claim that solidarity is univocal in what it and clear in what it requires, and that everyone should just always, you know, contribute to the same pool and pay according to their ability and have only one package for everyone. Rather, I think it is a value that is very important, and that in the broad outline, the value involves some form of risk sharing between rich and poor, between healthy and sick over a lifetime, and that this. I was trying to make the point that if people are going to, in the long run, support a system which will work only if it's relatively stable in the long run, as the systems we're discussing do, then it's important that they grasp the key rationales. Even though there are technical decisions to be made, it may sound like a technical decision. Should we have payroll-based contributions, or should we have tax-financed contributions? You might think, oh, you know, I'm checking out of that discussion. That's got nothing to do with me as an ordinary citizen. The point that, for example, also the case study in Ukraine makes is, no, you can't label this a technical decision and leave it to a bunch of technocrats, because at the heart of it is a value, which is, should what I get in terms of medical coverage depend on me working in the formal sector and making a lot, you know, having a substantial income, and therefore what I get out is what I proportionate to what I pay in, or are we all in this together in a kind of solidaristic way? That is a value judgment, which, as you pointed out, needs to be debated. But at least this moves that judgment into the realm of public debate and justification. And I was trying to forestall the idea that this is a purely technical discussion which we have to leave to experts. It's important that people can grasp the core justifications on offer, rather than that it's merely relegated to the realm of technocracy. That was the point I was trying to make. But of course, solidarity has different interpretations, and these should be debated. In relation to Mike, no, this World Bank report does not advocate the overthrow of all existing democratic, representative democratic regimes, nor does it even advocate the overthrow of undemocratic regimes. It's rather an attempt, and nor does it require, say, citizen participation in all forms of decision making, or any particular form that this citizens' participation should take. Rather, it highlights how, in a variety of contexts, ensuring real stakeholder engagement, where stakeholders can be both citizens and, say, in Ukraine, it involved stakeholders that were excluded in the reform process because they were mistrusted by the reformers, were the medical profession and local academics. Elina hinted at both of these things. And the idea is, you know, there is value in a variety of consultation and dialogical processes that go beyond, both in a representative democracy, go beyond merely, you know, having a hearing in parliament, and also can be required of, say, public bodies like, for example, in Britain, NICE, you know, the National Institute for Clinical Excellence, should have more citizen engagement with its, say, value judgments, because these things are not always best debated in Parliament by representatives, right? So the report proposes a variety of ways in which we open up discussion to stakeholders and citizens, including in non-democratic environments. So Thailand is a fascinating case study, because there, the way I mentioned it, it takes place in a military dictatorship. And we also cite a fascinating paper on the Chinese history of what's called by the author authoritarian deliberation, where institutions are set up within an authoritarian regime to enable input, correction of prevailing biases and mistaken views among the people who are actually making decisions, and criticism. And so the proposal is not the overthrow and going to some kind of Swiss-style direct democracy, but rather lots of different ways in which sometimes in a piecemeal fashion, you can make progress towards more open and inclusive deliberation.
Authoritarian deliberation reminds me of university settings.
Right, so let me just say, I want to acknowledge we are at time and thank everyone who isn't able to stay with us for a little more for joining us today. And I hope you've enjoyed our presentation and the discussions. And I also want to thank our speakers. I myself will have to go in a little bit, so I'll hand over the moderation to Nir, but our speakers have kindly agreed to stay for a bit longer. So everyone who can is, of course, invited to continue the conversation. Thank you all so much.
Thank you very much, Monica.
Have a good day.
So we turn now to Harold.
Thank you. Thanks for great presentations and a great report. Really look forward to digging more into that. So this connects both to the initial discussion about the value of procedure and Mike's point about the forms of public engagement. I put in the chat a link to a study, Julia Kreis, who's still with ICWIC, the German HTA office, where we mapped the kinds of public engagement that NICE did, that the French equivalent and the German equivalent did in both HTA and coverage decisions. And so to Mike's point, true, it could apply across, but it is interesting how in that sector, there is a number of different forms. And I guess what I'd be curious to hear your views on, and I was very intrigued by the point that some, in the Ukrainian case, some groups felt they weren't trusted, is there's an element of be careful what we wish for, I think. There's an assumption that public engagement is innocent and will just necessarily make processes better. But I also put in a really important study that my colleague Matt McCoy led on patient advocacy organizations and the extent to which they do or do not declare conflicts of interest. And you find more in the other paper on this too. So I'm curious how you think about ways of mitigating or acknowledging the risk that there can be forms of conflicts of interest too, or that there can be dark forces who will love this call for procedure and openness because they will seek to exploit it for their purposes. So much as I agree, public engagement can be a good thing, I think that the devil is in the detail, and we want to think about how we do it. And I think in pushing this, give people a little more guidance too on what to look out for.
Perhaps in Monica's spirit, I will ask also Kelsey Berry to send her question, and you two will have to deal with 2 questions. Okay.
Thanks, Mira. I actually wanted to also jump in and affirming kind of what I see as the importance of processes such as these. I mean, if we're kind of operating also with a Republican view of public autonomy, then it's part of human flourishing to be a co-creator and steerer of the collective life of one society. And so in some respects, these processes are necessary for that unless we somehow think that the decision makers have aligned values with the whole array of diverse constituencies within a society. So that might be not quite as aligned with some of the kind of liberal, a little bit more focused on private autonomy as a priority, but nonetheless, I think can be another dimension to affirming the moral importance of a process like this. Actually, I wanted to kind of pick up on Leah Pearson's kind of where she started us with, which was considering how resource intense and challenging these processes are to carry out, particularly in the circumstances and settings that are low resource, where there will be forced to trade off between funding processes like these and funding perhaps the outcomes of the decisions that they produce. And so I think the question for me is, how do you think about making trade-offs between expending resources on process versus on the implementation of maybe prior decisions or the kind of substantive judgments that were extracted from other decision-making processes. And I imagine, right, that making a trade-off between whether we do another process or whether we spend money on X kind of service could also be brought into the realm of public debate and justification, although then I think we're in a weird place of infinite regressive process. So there must be some moment at which the marginal benefit of more process is not worth the opportunity cost that it introduces. And wondering a little bit about the author's kind of perspectives on when that's the case, or are there certain threshold criteria by which we would consider the appropriateness of process like this relating to the level of trust that already exists in society. Okay, maybe that's a factor that reduces the import of spending on process, or the relative amount of power differential that already exists in society, the relative amount of inequality, especially if these processes are thought of as somewhat solves or a salve for those sorts of issues. So those are my questions. Thank you.
Alex, I can have a go first. And so and thanks everybody. It's a very kind of important question that we've struggled with when we were also working on the report and looking at the case studies. I just wanted to say that I think it's very important to emphasize, and that's something that we are also emphasizing, for example, because now there's a lot of work WHO is putting forward also on like social engagement, participation. Everybody's into participation, seems to be the stage. But I think it is important and the value of this framework, not just because I've been part of it, but I think the importance of it is that it looks at the process comprehensively, right? And I think it's very important to consider that participation is not direct participation, right? Is not the only criterion in this procedural fairness. And I think what you were saying, Kelsey, and I think Leah's point about the low resource settings was, and sorry that we didn't come back to it, but it's very important because I think not in every circumstance, you're right, the utility of that is like the benefit of it is not, doesn't outweigh the costs of such big processes of engaging every citizen, doing a polling and then doing citizens assemblies, which are expensive, which takes a lot of skills to do. And neither Kyrgyzstan, where I come from, nor Ukraine probably are in like the place to do it, right? But I think the point is that then you look at the other criterion, which I think Alex tried to hint on, is that and I think there's very nice work by Professor Eriksson from here in Norway, where he talks about the role of experts in democracy and the role of transparency. And so I think then you kind of try to compensate somehow with other criteria. So then you really, if this is delegated to the expert body, which in health very often purchasing agencies considered to be the expert bodies, right? They're supposed to be. Then you make sure that it's a very well documented process, that if there's a lot of reason giving, like in South Africa, when the Treasury made a decision on the health promotion levy, they literally made it their report in this Treasury website. I really encourage everybody to look at that report. It's like as if it's a peer-reviewed journal where they point by point response to each public suggestion that they received or public question on why this tax is not this way and not that way, right? And so I think, okay, they cannot go around engaging everybody, but to the questions that have been submitted, they've made this public report that is to this day on their website, where you very clear table, point 1, this is why we did it. Point 2, this is how we did it. And so I think we have to look at this as a process, and I really by no means advocate this kind of complete participation in every circumstance, right? And you're right, because we have to think of the resources that this process can use. Now, as Alex also said, there are some things that just have to be, it's better to spend the resources on that at early stage of the reform than to suffer the consequences later. Because some things like whether are we, let's say as a society, want to support this reform that is based on the principle of solidarity, that regardless of whether you have paid into the insurance system, you also get the service, or is it like, or do we want to have a more individualistic approach? I think that kind of discussions, there have to be like societal discussions. And some of it, for example, in Tunisia, post-revolution, there was this kind of cathartic experience probably of this social health dialogue where the big questions they discussed, and then the smaller questions of how to pay GPs, okay, that was delegated maybe to technicians. So, but whether, the architecture of the financing system, they took time to discuss as a society post-revolution. So I think that's kind of the important point to remember, that it's not just about participation. There are other things that you can do, like are not probably as cost intensive, and that for certain things it might be worth investing. And just to say that I come from a substantive fairness kind of field, and also all co-authors of the Ukraine report and many other. But I think you kind of learn that sometimes you think this is best for the people, because health financing people also tend to be arrogant. You think, I know best, that it's, you don't know that voluntary health insurance is bad for you. So I will not listen to you. But it's taking time to explain why voluntary health insurance is bad for you, and maybe why you should use general taxes. Maybe that's a better approach. Over from my side.
Alex, maybe I'll also ask you if you want to also say a few words to conclude. And all right, in that case, thank you everybody for soldiering on and staying with us for so long. Excellent discussion, and thanks also, Dan. We didn't come back to you, but I really appreciate your responses. So
yes, thank you all so much. Thank you, Nir and Dan, and everyone who asked questions. I've been taking notes along the way, and I know it will inform our work, and hopefully there will also be a review symposium in health economics policy and law, to which I know Dan will contribute his comments. So we'll keep learning from your feedback. Thank you very much.
Thank you.
Thank you all, and lovely to see so many familiar faces. Bye.